just give it 1 or 2 minutes, not long.
Yeah.
And then we're going to be discussing recognising the sick newborn. And Momo, if you have anything else.
Thank you for doing this, Lydia. Yeah.
Yeah. Is anybody able to maybe post something on the Facebook group just to let them know what we're doing? If they're kind of waiting, expecting, they can say we can. And what do you think?
I do it, Lydia.
Cool.
Thank you.
Thank you.
Yeah, you should.
Do you think I should begin?
Yeah, it's good, yeah.
Yeah, okay, brilliant. So we will start talking about, so last week we were talking about the resuscitation of a newborn, and this week we're going to talk about, so a resuscitation is when they're not breathing or their heart's not working effectively. So now we're going to talk about if they are breathing, but they're not well, so they're sick. So we're about identifying when they need emergency treatment, but is not yet a resuscitation, so that before they reach the stage of collapse. So that's our discussion for today. Okay.
See your presentation.
Great, and you can still hear me?
Yes.
Wonderful. Okay, so this is recognising the sick newborn. Important symptoms, signs, and emergency treatment. So the aim of this lecture is to recognise a high-risk infant and to be vigilant. So I think particularly now when it's maybe harder to access treatment, identifying early can be really important and can really save lives. So to understand and recognise the symptoms, common life-threatening conditions in newborns. So the things that happen to newborns are quite specific. And so if you know the signs and what to look for, you can be a huge help early on. And what we'll do is we'll go through and we'll use a structure. So this should be up on the Myanmar clinical guidance page as well. There's a structured approach to assessing a newborn with airway, breathing, circulation, coma convulsion, and dehydration. And we'll go through all of those together. So we're using that structure to help you be able to think clearly about what's happening to the baby in front of you. And then we'll talk about what's the immediate emergency treatment. Would anybody who is online mind just muting themselves? Thank you. Okay. So infants who are at increased risk of serious problems are going to be the premature or low birth weight. These babies are more vulnerable, and during the last weeks of pregnancy, lots of during the last Thank you. That's brilliant. Thank you very much, everybody. I know it's easy for that to happen. So during the last weeks of pregnancy, quite a lot of protection is passed from the mother to the baby in terms of infection markers, so protecting babies from infection. So if a baby's born early, they have quite a vulnerable immune system. So they are more vulnerable to problems, and they also struggle with their breathing because their lungs are not fully developed. So premature and low birth weight babies are at increased risk of problems. Equally large babies, so babies who are large for their gestational age, are often more vulnerable also for different reasons. So if a mother is telling you, oh yes, my other baby died early the baby has this problem, listen carefully, because that might mean that there's something genetic that may well happen again. Twins and triplets can often be smaller and therefore more vulnerable, especially if one of them is sick. There may have been a reason that also the other one has been exposed to. So if one is sick, observe the others carefully. A baby who's needed resuscitation has been through something quite dramatic with their body, and they will be more vulnerable afterwards also. So they need careful observation. A baby whose mother has had an infectious disease in pregnancy also is going to be more vulnerable. A baby who's born after the membranes have ruptured, so after that amniotic fluid, it's burst, it's ruptured, but then there's a long delay between that and delivery. Excuse me. This can lead, they're also more vulnerable if the mother's had a fever, or when the baby's born, if it's smelly. Babies with congenital anomalies and babies who are still recovering from serious illness are all at risk of serious problems. So there is quite a range, and I think just bear these in mind, and as we go through, things will be more clear. So I think, as always, preparation is key. So you'll need to think about, if you do find a sick newborn, are you in hospital or are you out of hospital? If you're out of hospital, where's the nearest oxygen? Where's the nearest person who is able to give treatment to a newborn? So what's your plan of how you're going to get there and what you're going to do? If you're in hospital, is the oxygen nearby? Who are you going to call for help? Who's present? Is everything kind of set up? So preparation can really also is key to saving lives. So starting with that assessment, I'm going to start with the airway. So emergency symptoms and signs in the airway. So we'd say stridor or obstructed breathing. So stridor is a noisy inspiration, so associated with work of breathing. So as you're breathing, as the baby's breathing in, you hear a noise. And it sounds very different to usual breathing, which you can't hear very much. So it's quite obvious, quite a clear noise. And once you've heard it and know what it is, so for example, if I'm working in my emergency department and I go into the waiting room and I hear this noise, I change, I look around for where it is. So it's kind of an inward, so you will know it when you hear it. But this can be due to lots of different things. So one thing that can happen to newborns, sometimes happens, is called laryngomalacia. So it's a part of the airway that becomes floppy, and that's causing the obstruction. And so when they're breathing in, they're having to go past that obstruction, and that could be challenging. There may be some other reason for obstruction, particularly after delivery. There may be blood, there may be vomit, or meconium, as we spoke about in the last lecture. There might be pressure on the airway for another reason. So, for example, a vascular ring, when the aortic arch has developed differently, it can end up that the trachea is through between the aortic arch, and that creates pressure on it. The airway can develop abnormally. So Pierre-Robin syndrome can be just due to the kind of mechanics, can be genetic, or it can be because of how the baby was positioned in the uterus. This leads to chin and a large tongue that goes
emergency symptom and sign airway or airway.
Sorry.
No, that's fine. I'm very glad people are here. Okay, let's keep going. So you can see here that basically anything that's going to put pressure on the airway is going to cause obstruction. So if you hear this noise, is everybody able to mute? Is that okay? Thank you so much, that's great. If you do have any questions or comments, that's completely fine, but maybe you could write them in the chat. I'd really, questions, comments are brilliant, but just put them in the chat for now, and that'll be wonderful. Thank you. So airway, any pressure on the airway might cause something like this. So these are the different things you can think of. So what we're going to do, we're going to give oxygen. And remember last week we spoke about positioning, what position a baby needs to be in to open the airway. So they're going to be lying on, supine and head in, not sniffing and not back, in the neutral position. You can, so if there's something obvious you can see in the airway, you can suction carefully, but only if you can directly see it. So you don't want to go try and taking out things you can't see. But if you can see there's something there, carefully suction. Sometimes you might need surgical help or anaesthetic help. So if you try to give oxygen, you try to suction, these things aren't working, you're going to need to get access to expert help as soon as possible. So I think that's part of your planning, isn't it? So if you're not in the hospital and one of these happen, you've got your immediate things you can do, which is to support the airway. And if there's anything obvious in the mouth, to remove it, but only if you can see it. But then you're going to need to find the next level, which is surgical or anaesthetics. So plan carefully where this is. Okay, so we've done the noise that you can hear, so stridor, and now what can you see? So obviously cyanosis, so that's a sign of low saturations, and it can be a discoloration, a kind of bluish colour. Look at the lips and the gums. It can be quite difficult to detect sometimes, and sometimes a mild change in colour is actually quite profound drop in saturations. So if you can, assess by looking, but also check the saturations if you have access to a pulse oximeter. When you have a newborn, because of the way that the heart is adjusting post-delivery, always use the right hand. Okay, so in a newborn, we use the right hand to check oxygen saturations. If you don't have access to a pulse oximeter and you can see that there's some cyanosis, or you think maybe there is, give them oxygen. So to give just 0.5 to 1 litres per minute by nasal prongs and observe how that changes and what they look like. Okay, so that's if either there's visible cyanosis or if the oxygen levels are less than 90%, you're going to give oxygen if you have access to it, 0.5 to 1 litre per minute by nasal prongs. Okay, and we're going to put that airway in a good position. I'm going to keep going. Okay, so that was airway. Now breathing. So we're going to look at a pattern of breathing. So that's how the baby's breathing. So are they breathing fast, which is more than 60 breaths per minute in a newborn? It's really important that you do count for a full minute, because some babies, well, all babies breathe a little bit fast, maybe for a few seconds, and then slower for a few seconds. So they don't breathe regularly. So if you just count for a short period and then multiply, it won't be accurate. So stay and watch them for a full minute to look at their breathing and to count. And apnea is when there's a pause in the breathing, so when there's no breathing. Shallow or irregular breathing is when they're taking breaths, but they're not fully expanding their lungs. So they're kind of just doing the edge of it, just small breaths that will not be effective. And gasping, we spoke about gasping last week. So it's quite a sudden, deep, but irregular breathing. All of these, apnea, shallow or irregular breathing, and gasping, they're all signs that the baby is exhausted or is not breathing well, and it will soon go into full respiratory arrest. So a baby who's taking pauses where there's no breathing, a baby who's breathing shallow and irregularly, or a baby who's gasping is a baby who's soon going to stop breathing entirely, so you need to support their breathing. So you're going to give them oxygen and you're going to be ready to give them bag, mask, belt and ventilation if they need it. Okay. You might also see increased work of breathing. So that'll be grunting. So stridor was an inspiratory noise, so you hear it as the baby breathes in, whereas grunting is an expiratory noise. So it's kind of like it sounds. We'll watch a video in a minute. Head nodding is when, with each breath, the baby's having to use their head. So their head is moving. You also sometimes see some nasal flaring, so the nostrils are moving. Tracheal tug is when you can see with each breath the trachea is moving in and out. Or chest wall indrawing, when you can, as the baby's breathing, you can see the shape of the ribs. You can see it moving in and out. For these things, you're going to give them oxygen, and if you have access to it, consider CPAP. So if you're at home, you're going to keep the baby airway in a good position. If you have oxygen, you can give it, and then you can consider where can you get CPAP? Where are you going to go? What's the nearest place you can care for a baby? And get there as soon as you can. So we're going to watch this breathing. I think we did some of this last week, but let's go again. So we'll watch it 1 or 2 times, and then I'd like you to tell me what you can see. So why don't you write in the chat what you're seeing with the baby? Okay, let's go one more time. Okay, what can everybody see?
Tomorrow chat box မှာရေးပေးပါ
Would you mind reading the chat to me? I can't see it when I've got my screen up.
There's nothing coming in.
Okay.
လေး
Okay,
သက်ရှိ
no.
ပုံဘာတွေဖြစ်လဲဆိုတာရေးပေးလို့ရတယ်နော် chat box ထဲမှာဆရာမစောင့်နေရေးပေးမယ်ဟာဟုတ်တယ် let me read out chest drawing.
Yeah.
I'm write down chest drawing. Trachea tug, another one.
Great.
2.
Brilliant. Okay, they're both really good things to notice for sure.
Chest and drawing. Yeah.
And what could everybody hear? What could you hear?
Oh, we didn't hear any sound from.
Oh, you didn't hear sound?
Yeah.
I think this has happened before with my laptop. Don't worry, you'll be able to hear sound, but the baby is, so this baby, when you watch it back later, is grunting, okay? So what we can see as we go through is you can see definite chest indrawing, absolutely. Here, this is the tracheal tug. And then can you see the nostrils as well? Each time the baby's breathing, they're going in and out. So that is nasal flaring. Okay, and this, the baby looks tired. So we'll go through these other signs as well, but you can see instinctively that this doesn't look like a well baby. This looks like an unwell baby, but it's very good to be able to say, okay, but I can see this sign, and this sign. And it gives you a structure for your assessment, even though you know they're not okay. To be able to communicate why and what you're seeing can really make a difference to the next step. Okay, so this is another baby who's also got severe chest indrawing. And you can see also some tracheal tug there. And they're moving their head slightly with each breath. So I think if the baby was in a different position, you'd also see head nodding. Okay. Okay, and this is the last one of respiratory distress. So you can see that's the tracheal tug here, and this baby is grunting. So with each breath, you can hear a kind of pushing sound in their airway, and that's him trying to keep the airway open, trying to maintain his own pressure. Okay. Watch one last one. So that's definite head nodding there. You can see the baby's moving his head with each breath, and some also lower chest wall indrawing. And he looks tired. This isn't what a healthy baby looks like. You know, his head's back, he looks lethargic. Okay, so if you have a stethoscope, you can also listen to the chest. So you look at the pattern of the breathing and then what you can hear, and if there's increased work of breathing, but you're also going to listen if you can. So look for asymmetry of chest sounds. So you're going to listen to both sides and see if they sound the same. You should always hear something, and if you don't hear anything, check your stethoscope first, and if your stethoscope is the right way around. And if you still don't hear anything, that's a very serious sign. You need to get help immediately. If there's no breath sounds in one side, but you can hear in the other, that may be a pneumothorax, okay? And that can happen particularly to premature newborns, so it's something to look out for. And then you've got also, if they're breathing and you see that their chest is moving differently, so one side is expanding more than the other, that's also a sign of pneumothorax. You're going to listen for crackles or crepitation. So this kind of sounds like a plastic packet crunkling together, and I'm sure lots of people have heard it, but that can be a sign of pneumonia. But I'd say if you're hearing these things, you need to get to hospital very quickly. Okay, so what to do with respiratory problems? Get senior help to establish diagnosis. So we are noticing the danger signs, the early signs, and then our main job as a nurse is to escalate. So you identify there's a problem and get access for help. You might want oxygen. Be prepared to give the bag vast ventilation, like we spoke about last week, and consider CPAP. For a pneumothorax, you might need to remove the air. This is an emergency procedure. It should be done by somebody who's been trained. And you will need to be in a hospital for this. So this is something to get fast access for help. What they do is put a small butterfly needle in to drain the air, but it's an advanced procedure that you need advanced resuscitation skills for. Okay, so we've done our airway and our breathing, and now we're on to circulation. So we're going to listen to so you can listen with a stethoscope for the pulse rate. A heart rate that's more than 160 beats a minute is too fast. A heart rate that's less than 100 beats a minute for a newborn is too slow. So you're going to listen, that's the rate. And then you're going to feel the pulse. So in a newborn, it's very difficult to feel the radial pulse, or can be quite chubby. So we tend to go for the brachial pulse. So feel for the brachial pulse if it's a poor volume or difficult to feel. Then we're going to feel their hands and feet. Are they warm or are they cold? If they're cold, you're going to feel up the arm to see at what point they become warm. So you could say arms are cold up to the elbow, or just the hands are cold and the arms are warm. Then you're going to check the capillary refill time. So press your finger onto the sternum for 5 seconds, then let go and count how many seconds it takes to go back to the same colour. If it's more than 3 seconds, then that's prolonged. So if you have a slow or a fast heart rate, a pulse that's poor volume or hard to feel, cold hands and feet, and a prolonged capillary refill time, then the baby's in shock. This is an emergency and you need to get treatment as soon as possible, within minutes preferably. We're also going to look to see if the baby's pale and see if they're dehydrated. So that will be, the baby will be lethargic with a prolonged skin pinch and sunken eyes. So this is how to do a skin pinch. You pinch this part between the umbilicus and the rib, so you pinch here. And normally when you let go, the skin will completely go back. A slow skin pinch will stay like this for about a second, for more than 1 second. And a very slow skin pinch will go back for more than 2 seconds. So this is a sign of dehydration. And this is what we mean by sunken eyes. So you can see the eyes have gone further. You can see the shape of the bones more, and their eyes are sunken into their head. So these are 2 signs of dehydration. So, prolonged skin pinch and sunken eyes. So if a baby's in shock, we're going to give 10 millilitres per kilogram of ringer lactate or normal saline over 30 minutes and reassess. So if they are still in shock after 30 minutes, you're going to give the next one. We also want to be able to check their blood sugar, because they may, if they're in shock, they've had diarrhea, they may have a low blood sugar. So if you can't check their blood sugar, you can give 2 millilitres per kilo of 10% dextrose. This is all hospital-based emergency treatment, and I don't know what access you have to things, but you will need somebody who's competent to assess the child and prescribe, so ideally a doctor. You need somebody who is able to put an IV line in, and you're going to need all the access to all the right equipment. And then this child is going to be sick afterwards. So you're going to need somewhere where people can, where the child can have ongoing care, okay? So if there is access to a hospital, take the child into the hospital. Okay, so treatment of our dehydration in neonates. We're going to want to increase the breastfeeds, both in how often you do it and how long they're feeding for. So feed them more often and for longer. But if they're not feeding, you can attempt to feed, and then you can give any extra breast milk. So you can express and give it by spoon, a cup and spoon. If feeding's very poor, give express breast milk as much as possible, and you can give also IV fluids. So I've got a little video of this baby, and I would just like you to write in the chat if you think this baby's feeding well or not, feeding well or not feeding well. What do you guys think? Is the baby feeding well or not feeding well?
Để xem ở chat box ထဲမှာရေးပေးပါနော် Someone said not feeding well.
Yeah, I completely agree with you. So although the baby is here, is awake and is showing some signs of wanting to feed, actually you can see is not latching on the breast well and is not sucking. So just because they're close to the breast doesn't mean they're feeding well. So you need to do a careful assessment really of how the baby's feeding. Sometimes they can be in this position, and if you don't have experience with newborns, it's easy to consider that they are feeding, but this is baby who's not feeding, and they will need extra support. And try not to let them spend too long trying, because they will get more tired. So after 15 minutes of trying on the breast, if they're already dehydrated and they're not feeding well, stop and express and give by spoon, so you know how much they're having. Okay. So convulsion. So a coma or a reduced level of consciousness. In adults, we obviously use GCS, the Glasgow Coma Score. In newborns, we can assess the tone, the spontaneous movement, and the reflex. This is a little bit like, remember we did the APGAR score last week. So, or just the assessment of the baby. So you want to look at how their body tone is. Are they a normal, an alert baby will have some tension in the arms, so they'll be kind of held up, and the knees are often up to the chest. A baby who's not alert or has a reduced level of consciousness can often be floppy. So their arms will be down and their legs will also be heavy. Babies make spontaneous movements that are not repetitive. They move in different ways. So they should be making small, infrequent movements, small different movements. And they have reflexes also. So if any of these things are gone, then the baby has a reduced level of consciousness. So let's look at some of these things. So if they have these, we need to check a sugar. And this is for a baby. If it's below 2.6 or below 45, then you're going to give treatment. Above 2.6 or 45, depending on how you mark it, then that's okay. So this is a baby who has seizures. So let's have a little look. So can you see he's making movement, but they're very repetitive, these movements, and they're all kind of coming in, okay? So they were affecting his legs, his arms, and you can see some around the eyes. So these are not normal movements for a baby, okay? Whereas this, we've got a sucking reflex. He's alert. Sometimes staring, and is making some movements. So that looks quite different to this baby. Not looking around, they're repetitive movements. Neonatal seizures can be quite difficult to spot because this is quite a clear example, but it can be just one limb, or it can be kind of just the eyes. So watch your baby carefully, and if you're not sure, take them for escalate to senior help for further assessment. So if a baby's having a seizure, we're going to need to maintain their airway. So remembering that airway position we spoke about earlier, put them in the neutral position. You're going to give them oxygen, and we're going to check their blood sugar. So these are three things you think when you see a baby having a seizure. Immediately you think, airway, is their airway safe? I need to give them oxygen, and we're going to check a blood sugar. The reason we check a blood sugar immediately is because the baby can have a convulsion for having a low blood sugar. So, and if a baby has a low blood sugar and we give other medications, it's not going to work. You need to treat the low blood sugar. So check it immediately, and if it's below 2.6, then you can give treatment. So if the blood sugar is low or there's no glucometer available, you can't check, you can just give 2 milliliters per kilo of 10% dextrose IV. And then we're going to give phenobarbital deep IM or slow IV. So this is important, we don't give it too fast, because if you give too much or too fast, the baby can stop breathing. Okay, so you need to weigh the baby, know how much they weigh, 20 milligrams per kg as a loading dose. It should be given over 10 to 15 minutes, ideally with a syringe pump. If we're giving these medications, we need to be in a hospital. You need to be somewhere where the baby can continue to be observed and where there is senior help. Okay, so this is ideally what we need to be doing, but consider where you are. So that was treatment of seizures. Other signs to look for. If a mother's telling you the baby's not feeding, take a recent change seriously. Often what happens is the baby will change their behaviour but continue to look relatively, they look unwell but not so dramatically, and then quite soon after they do become very unwell. So a baby not feeding and a recent change, take what the mothers are saying seriously. They know their babies, they know when things are changing. If a baby's vomiting, if they're vomiting everything they eat, they then vomit. Or if when they vomit, it's bilious, so it's looking kind of green or like bile rather than like milk or digested food, then take this very seriously. If they're bleeding, so if there's any bleeding from the umbilicus, from their nose, their mouth or their rectum, take this seriously. Equally, an abnormal cry. So if when they cry, it's a very high pitch and it sounds, so if you listen to a baby cry, they can change their tone, but there's kind of a very high pitch continuous sound that can be a serious sign. Or if when they're crying, they're not making any noise. All of these are important things to look for. So if a baby's not feeding, assess them carefully for sepsis and then give treatment. And then we're also going to help the mother with the breastfeeding, so she'll need lactation support. If a baby's vomiting everything or having bilious vomiting, we're going to need to, if you're in a hospital, ask a paediatrician to examine them for intestinal obstruction or consider meningitis. If you're outside of the hospital, you need to take them to the nearest place where they can care for newborns. Okay. If they're bleeding, either from the umbilicus, from the mouth, nose or rectum, check if they receive vitamin K at birth and give another dose. We also need to make sure that they're somewhere where a baby who's bleeding a lot might need emergency treatment or need a blood transfusion. So again, knowing where you can access help is important. Okay. Now, signs of sepsis. So sepsis is not easy to see in a newborn, but it can progress very rapidly. So that's where if a mother says something's changed, you really need to listen. Signs of sepsis include poor feeding, lethargy. So, you know, before we saw that baby in the mother's arms where the arms were floppy, their head wasn't being held up, and they should be making small spontaneous movements. They're not doing these things. It's a sign of sepsis. If their temperature's been either low or high, if they have kind of pale grey or mottled skin, so you can see mottled means, can you see all these lines? You kind of get this network of dark colour and then a lighter colour in the middle. That's mottled. If they look jaundiced, jaundice can be connected with sepsis. Or if they have abdominal distension, so if their abdomen is kind of getting larger and protruding. So all of these are signs of sepsis, and we need to be able to identify these babies and get them treatment quickly. The timing of the treatment can really make a difference to the outcome and to the survival of the baby. So abdominal distension. If the abdomen is distended, I've got a picture there. So particularly in a newborn, they shouldn't be kind of protruding so much. You want to make sure, ask about vomiting, ask if they've passed stool or urine. With the stool, the first stool we've spoken about before should be meconium, which is the thick kind of black, dark green, sticky substance, which after a couple of days changes to a seedy stool. So we want to know if they've passed stool and what's it's like. Have a look at the baby to see if there is any one place in the abdomen where it's different, so kind of a mass. Look at the anus to see if it's patent. Some babies can be born with a closed anus, and that will need surgical treatment. These babies won't have passed stool. And if you have a stethoscope, you can listen for bowel sounds. No bowel sounds is quite a serious problem. And you also need senior help. And then the skin might change. So as it gets bigger, it kind of gets tight and shiny and red. These babies get sick very quickly, and they need expert treatment. So if you see these things, get senior help. Don't feed the baby. If you have an NG tube, pop them on an NG tube and open it, so that if there's anything in the abdomen, it can drain, and we can support them with IV fluids. You don't want to leave a baby nil by mouth with also no IV fluids. They need some kind of hydration. So if you decided to have the baby nil by mouth, you're going to need to get them help as soon as possible to get them on a drip. And when I say as soon as possible, I mean within an hour or two, because they already won't have been feeding. If they've got all of these signs, they're not absorbing properly, so they're likely to already be compromised. If you leave a baby nil by mouth and don't support them with another way, so IV fluids, they're likely to end up in shock. So that needs to be managed. Okay, the last thing is to look for is meningitis. So again, the signs can be quite subtle in babies, and not every baby has all of the signs. So here you can see, so every baby has a fontanelle, which is like a gap in between their cranial bones, and that normally it will be flat. So if they have a bulging fontanelle, you can see this bulge up here, that's a sign of meningitis. So meningitis is, I'm sure you all know, a kind of an infection of the layer around the meninges, which is part of the layer around the brain. So it's an infection there in the spinal fluid. They might be irritable. So remember we spoke about that high-pitched cry. So that kind of a baby that if won't feed properly, they're not feeding well, they don't settle after a feed. If you swaddle them, they're still crying and they're reduced in consciousness, this can be a sign. They may end up having convulsions, and they might often take this position, so arching the back and the neck. To be managed properly, they'll need a lumbar puncture, where you place a small needle in the back to aspirate some of the spinal fluid. This is this procedure carries risks, but what you're doing is assessing for any infection. You'll need a laboratory that's able to process this, and a full treatment for meningitis is 2 to 3 weeks. So this is really just to tell you what the correct management is, but it's likely that many hospitals, or certainly station hospitals, will struggle, and only you need somebody who has been trained and practiced in this, because it's a procedure that carries many risks. Okay, so we've gone through danger signs in airway, breathing, circulation, convulsion, and a few other specific conditions. Do we have any questions? No, that's okay. So I'll just do a quick summary, and then feel free to write any questions down. So in summary, we need to be aware of the risk factors. So be aware of which babies to be ready for, like we spoke about at the beginning. With all sick babies, we're going to follow our pattern. So look for the airway, make sure we put them in the safe airway position, neutral. Review their breathing, look at the pattern, look at the speed, listen to what you can hear, give oxygen and treat quickly. Circulation, look for shock or anemia. Coma convulsion, think about blood sugar and anticonvulsant treatment. Look for dehydration, about feeding and fluids. Other things to consider are sepsis, abdominal obstruction, and meningitis. Okay. We're still here for questions. I thought if anyone wants to go directly.
Morning, Lydia. How are you? I'm so sorry that I was dealing with a collapsed individual at a bus stop. It's all fine.
Fine.
Thank you so much for this session. That's been great. We have quite a lot of guidance on the website, right? So if people are not sure about what to do around neonatal sepsis, that's an important thing. I'm just keeping an eye on the chat as well, just to see if there's anything there. But I don't think we've got any questions on this. That must have been very, very clear. Thank you so much. That's great. I think we're all done.
We won't manage to stream it, so we're going to record it.
We've got to record it, and we'll put it on the Facebook Live. Absolutely right. Yeah. No, that's my fault.
No.
Thank you so much for saving this morning. I have to say, it's much appreciated. Tomorrow, everyone, we have the Sepsis 6, and that's our teaching for tomorrow. And I'll put a link up on the Facebook page today. But if there are no further questions, then I think we should. Stop.
Okay. Nice to see you all this morning.
Thank you so much, everyone. Thanks, Lydia.
All right. Thanks, everyone. Bye.
Bye.